Before we dive in, a quick request. Please subscribe, like this episode, and tell us your next community medicine topic in the comments. Your picks shape our lineup. Welcome back. Today's revision episode is Health Insurance and Financial Protection in Indian Healthcare. We'll connect the economics you're asked in Viva with the flagship schemes you'll see on postings. With us is community medicine specialist Dr. Joshi.
Delighted to be here.
Let's open with the burden of paying for care. Dr. Joshi, set the context and the big goal.
Health financing borrows ideas from economics, needs, demand, utilization, price elasticity, because systems must match resources with population needs. In today's day and age, an episode of sickness clubbed with hospitalization can wipe off a significant chunk of middle class or lower classes' lifelong savings. India historically relied heavily on out-of-pocket or OOP spending. The direction, though, is improving. Recent national health accounts show the OOP share falling to about 2/5 of total health expenditure, yet it still burdens families. Catastrophic spending crossing 10% of the household budget hits roughly 1 in 6 Indian households in recent analyses. The policy goal is clear: universal access to quality services without financial hardship.
That brings us to Ayushman Bharat. Two pillars, right?
Yes, Ayushman Bharat, announced in 2018, has 1. Health and wellness centers for comprehensive primary care, and 2. Pradhan Mantri Jan Arogya Yojana, PMJ or PMJ, for financial protection at secondary and tertiary levels. PMJ is entitlement-based. Identified families receive cashless, paperless hospitalization in empaneled public and private hospitals. It uses deprivation and occupational criteria from the socio-economic caste census 2011, and it explicitly includes previously covered families from older schemes.
Give us the crisp numbers and benefits students must quote.
Coverage up to Rs 5 lakh per family per year for hospitalization, no cap on family size or age, no exclusion for pre-existing conditions, and a national network of empaneled healthcare providers, EHCP, enabling cashless care at point of service. Current official descriptions place the potential beneficiary universe at over 12 crore families, around 55 crore people.
Case Vignette 1. A 52-year-old informal sector worker arrives at an empaneled private hospital with acute coronary syndrome. He has a PMJ eligibility card. What happens next?
The hospital performs e-verification, submits an e-pre-authorization for the relevant package, and provides cashless treatment if approved. Discharge, e-claim, and payment are digital. For Viva, say entitlement-based, cashless, paperless, package rates, portability within the network.
Let's step back to older government insurance, RSBY, and how it fits in today.
Rashtriya Swasthya Bima Yojana, RSBY, was a central health insurance scheme for below-poverty line households in the unorganized sector, offering up to Rs 30,000 per family per year on a family floater basis with a smart card cashless admissions. Importantly, PMJ has subsumed RSBY, and active RSBY families were part of the targeted groups when PMJ launched.
Insurance isn't the only pillar. What are the maternal protection schemes students must name?
2 big ones. Janani Suraksha Yojana, JSY, launched in April 2005, a 100% centrally sponsored safe motherhood intervention to reduce maternal and neonatal mortality by incentivizing institutional delivery with special focus on low-performing states. Janani Shishu Suraksha Karyakram, JSSK, launched June 2011, entitles all pregnant women delivering in public institutions to absolutely free and no-expense delivery, including cesarean section, plus drugs, diagnostics, diet, user charge waiver, and free transport to, between, and from facilities. Sick newborns and infants are covered for free care and transport.
Quick compare for the exam. How do these maternal schemes complement PMJ?
JSY and JSSK reduce the cost and access barriers for normal and complicated deliveries in the public system. PMJ shields the poor from high-cost secondary and tertiary hospitalizations, public or private. Together, they cut the probability that childbirth or complications push families into debt.
Now, alternative financing models and real-world challenges.
First, private insurance coverage remains limited compared to the population,
and most products emphasize inpatient care. As coverage expands, regulation of private providers and standardization of packages, quality, and fees become critical. PMJ package rates and empanelment norms are steps in that direction. Second, community-based risk pooling has been encouraged under the National Urban Health Mission via Mahila Arogya Samitis (MAS), women's collectives that mobilize communities and can facilitate local risk pooling mechanisms. Third, states have run their own risk protection schemes, e.g. Arogya Sri in Telangana, Mukhyamantri Amrutam in Gujarat, and cooperative-based Yashaswini in Karnataka, often aligning or interoperating with national rails over time.
We also hear about special insurance for family planning services.
Correct. The National Family Planning Insurance or Indemnity Scheme provides compensation to sterilization acceptors and indemnity to providers in case of rare adverse events, failures, or complications. It reduces litigation fear and protects clients, supporting access to safe, quality services.
Case Vignette 2. A block program manager asks how to lower catastrophic spending in their district this year. What's your 3-point actionable answer?
1. Maximize PMJ utilization among eligible families, active identification at OPDs, on-site help desks, and grievance support to prevent balance billing. 2. Strengthen public facility entitlements for maternal and newborn care under JSSK and ensure JSY payments are timely. 3. Run essential drug and diagnostics availability audits so public facilities reliably substitute high OOP purchases. Track weekly stockouts and fix procurement bottlenecks.
Students often ask, if PMJ exists, why do OOP bills persist?
Because many expenses fall outside hospitalization packages, OPD visits, long-term medicines, diagnostics done outside networks or non-adherent provider practices. Also, not every eligible family is aware or successfully verified. That is why financial protection requires both A. Insurance for inpatient catastrophes and B. Strengthened primary care, free drugs and diagnostics and rational pricing. The downward trend in OOP share shows progress, but coverage and compliance have to keep improving.
Microviva. Short, high-yield clarifiers, please.
Sure. Define catastrophic spending, household health payments exceeding 10% of the total budget. State 4 PMJ features, Rs 5 lakh cover, cashless and paperless, no family size or age cap, pre-existing diseases covered. Name 2 maternal entitlements under JSSK, free C-section and free transport home facility home, plus free drugs and diagnostics.
Principles time. How should we evaluate financing reforms in answers?
Use 3 lenses. Financial risk protection, did catastrophic and impoverishing expenditure fall? Service coverage, are needed services actually used equitably? And quality and efficiency, do packages buy effective appropriate care? Quote trends, falling OOP share, and link to mechanisms, entitlements, empanelment, pricing, and grievance redressal.
Quick pause and recall checks for active learning.
Pause and recall, which census underpins PMJ eligibility? Answer, Socioeconomic Caste Census 2011. Pause and recall, which 2 schemes together ensure free delivery and transport in public facilities? Answer, JSSK plus JSY. Pause and recall, what is the per family annual cover under PMJ? Rs 5 lakh.
Final minute, wrap our main messages, Dr. Joshi.
India's financial protection architecture blends broad insurance, PMJ, with public entitlements like JSY and JSSK, and with state schemes and community platforms such as Mahila Arogya Samitis. Your exam frame is simple. Describe the OOP problem and catastrophic spending. Explain how entitlement-based cashless schemes shield families from hospital costs. Name maternal entitlements and add how community and state initiatives close gaps. Above all, tie every scheme to the goal, universal access without financial hardship. And the trend data show India can move there with continued expansion, better awareness, and strong primary care.
That's our time. If this helped your revision, hit subscribe, like the episode, and tell us the next topic. See you soon.